Hello, and welcome to Conversations with Dr. Kohli. I'm your host, Dr. Payal Kohli. I'm an associate adjunct professor in the cardiology division at Duke University and the founder and medical director of Cherry Creek Heart in Aurora, Colorado. And today, I'm delighted to be joined by my colleague, Dr. Nancy Albert, who is the Associate Chief Nursing Officer at the Nursing Institute at the Cleveland Clinic. And she's also a clinical nurse specialist at the Linda H. Kaufman Center for Heart Failure Treatment and Recovery at the Cleveland Clinic. Hi, Nancy. Welcome.
Hi, nice to be here.
So, Nancy, tell me a little bit about yourself. I know you wear a lot of hats, which, as a female clinician, you've got a researcher hat, you've got an administrative hat, you've got a clinician hat. So talk to me a little bit about how do you juggle all this on a day-to-day basis?
Well, juggling is always interesting from day to day, I'll tell you that. So my main role, though, is to be a research scientist, and it includes my own program of research, which I take a lot of pride in and have a lot of passion for. So I'm always trying to better understand the biobehavioral outcomes of patients with heart failure based on different interventions, especially self-care interventions. And my other program of research is really looking at guideline-directed medication therapies and seeing what we could do to have better outcomes for our patients so that they have better lives. So I get to weave a lot of it in. I see patients clinically, which helps inform my research, and then I do the research, which helps inform the clinical outcomes. So it all kind of meshes together in an odd way.
Well, it's truly admirable, all the hats that you're juggling, and kudos to you to really try to make a difference in the science and the lives of our heart failure patients, where I feel like up until recently, especially for HFpEF patients, we have really had such few options and such few therapies to offer them.
It's so true. In fact, one of the therapies we used to offer, beta blockers, is now kind of off the list. So we're taking things away, and although we've just added on SGLT inhibitors, so that's a plus for us.
For sure. And so I want to spend time talking about this class of medications today because, obviously we've gotten some experience with empagliflozin and dapagliflozin, which are SGLT2 inhibitors. But now we've got this new kid on the block, which is sotagliflozin, which is a kind of almost a new in class because it's an SGLT1 and 2 inhibitor. And we've seen it hit, for the same types of outcomes, HFrEF, HFpEF, chronic kidney disease. We've even seen some benefit actually for ischemic stroke. So I want to share with you a little bit of data that was presented on sotagliflozin at the European Society of Cardiology meeting in London. I didn't get to attend this year because I had a family conflict, but I definitely saw the science and I was excited about it. And I'm curious to hear your reaction. So because HFpEF has been this really sort of mystified condition where we haven't had a lot of therapies, this was an analysis really looking at two different phenotypes of HFpEF and sotagliflozin and how the risk reduction works. So one was the phenotype of HFpEF driven by obesity. So they stratified patients in a pooled analysis of soloist and scored, looking at their BMI. And the patients with a BMI above 30 actually had a positive interaction value for the benefits of sotagliflozin, suggesting that obesity-driven HFpEF phenotype may have some special benefit with respect to SGLT1 and 2 inhibition. And the second analysis actually looked at, stratified by EF. So whether your ejection fraction was less than 50% or greater than 50%, what your risk reduction was in the soloist trial. And interestingly, there was a greater relative risk reduction if your EF was greater than 50%. So it was a 27% relative risk reduction for the HFpEFers compared to a 22% relative risk reduction for the HFrEFers. So still very robust, obviously, across the spectrum of EF, but really interesting to see almost more bang for your buck coming out of HFpEF. So tell me, does that change your thinking? And how do you think about this medication in your HFpEFers?
So I'll tell you, it doesn't change my thinking so much because we started using SGLT inhibitors in the HFpEF population when earlier research came out. I think what maybe changes our viewpoint a little bit is thinking about the individual scenario with each patient. Certainly, if they're more obese, this may be a good drug to use. And also, we know that sacubitril valsartan, as an example, seems to work best, at least in males, if the EF is less than 60%. So not all HFpEFers may benefit. But knowing that an SGLT class of drug is going to benefit whether your EF is closer to 50 or whether your EF is above 60 is really important for us because up till now, we really have not had a lot we can offer our HFpEF population. So I'm actually very excited about it. And we have started to use SGLT2 inhibitors in our patients with HFpEF so far. So we've been doing that already.
Great, fabulous. And I think we're going to continue to learn more about HFpEF, really individualized treatment, as you pointed out, use the BNP, use the clinical clues, and realize that we sort of box everybody into the HFpEF category if the EF is over 50, but there's probably actually some heterogeneity with respect to what's driving that HFpEF, whether it's obesity, whether it's diabetes, whether it's your sleep apnea, whether it's other conditions as well, cardiometabolic disease. All right, so I want to ask you some clinical questions. Before I do, I wanted to mention, of course, that sotagliflozin is actually now being studied in hypertrophic cardiomyopathy, which is almost a different beast altogether. Obviously, you have diastolic dysfunction. You may have some systolic overreaction as well. But to me, that's another one of those conditions where we've had such limited treatment options for so long that I'm really excited about.
Yeah, I think that is very exciting. It's amazing how many HCM patients have come out of the woodwork since there's been ads on TV for another drug that's available. And I think that's helping us to better understand the total population that have it. And the more we learn, the better we could treat these patients medically. So maybe they don't have to go on to having drugs that have side effects that could cause harm down the road. Where the SGLT family does not have the same risk profile as some of the other drugs. So in terms of ongoing monitoring.
That's such a good point. So, okay, so let's dive in a little bit into those SGLT inhibitors. And, before we only had the SGLT2s, the empagliflozin, dapagliflozin. Now we have the 1 and the 2. So if I'm a patient in your clinic and I've got, HFpEF, for example, or even HFrEF, how do you decide which SGLT inhibitor are you reaching for? Are you thinking about specific things, or do you think it's really dealer's choice?
I actually do think for right now, it's dealer's choice because I haven't seen enough literature to make me think otherwise. And to be honest, in my clinic, we don't have SOTA on our pharmacy and therapeutics committee yet. It has not been approved. So right now, my two options are EMPA and DAPA. Once sotagliflozin does get approved for use, I want to do the same thing, but with all three. And that is that I start with one and I try to alternate them because I'm trying to, behind the scenes, figure out on my own, do I see less side effects if I use DAPA versus EMPA and then eventually SOTA just within my own patient population? So how often do I get into trouble with it? But I'll tell you right now, my limiting factor has been, because when I talk to patients, even if they think they're feeling fine and I explain why we need to use it, almost all will say, okay, I'll take it. So getting patients to go on it does not seem to be a problem for me, probably because I do spend that time. But I'd say half of the time when I go into the system to order it, I get kickback from the local drugstore, the pharmacy, saying that their cost is very high and the patient sees the cost and either tells me they can't afford it or they can't even take it because their insurance won't allow it. There's a preconceived hierarchy in the insurance system. And so I think the real issue is going to be down the road, how well can all three of the drug companies get their drugs into the system in a way that we can make an educated choice on which drug we want to use, if indeed we want to mix it up based on patients' obesity, for example, or some other condition or some other factor going on. Because right now I'm not seeing a huge difference in terms of clinical complications based on which drug I'm picking.
I mean, I think you made some really good points there. The first is the cost is always the limiting step for everything we do. And until we can really get the payers to come on board with the indications, I think there's always that lag that makes us as clinicians really frustrated. I have found some interesting differences, I think, between some of the endpoint signals. So, for example, the ischemic stroke signal, which we did not see with EMPA, DAPA, we do see with SOTA. Obviously, we talked about how there's gut receptors with the SGLT1, not just the kidney receptors. So could there be a phenotype of patient that might benefit or have less of a side effect profile, as you said, from using a combined SGLT1 and 2 inhibitor versus just an SGLT2 inhibitor. And then the diabetes type 1, I have to say I haven't been brave enough to write an SGLT for a type 1 diabetic, but we know that in Europe, that sotagliflozin does actually have approval for type 1 diabetics that may be coming here in the United States. So I think it's sort of like your ARB. It ends up being dealer's choice, but there are going to be some subtleties that do end up guiding us clinically and make it different. So, you say you get your patients on this, and I'm so happy to hear that you spend time educating them. Can you give us some quick pearls? Because I have a lot of women, for example, in my clinic who are postmenopausal who get frequent UTIs, and they need an SGLT2 inhibitor because they have PEP. So for that type of a patient, what might be something that you might do to try to get them on this class of medications?
Right. So if I have somebody with frequent UTIs, I let them know that there is an elevated risk, but it's more perineal than it is UTI. And I explain to them, I use baby wipes as an example, and I say to them, go out and buy a box of baby wipes at your local drugstore. And every time you go to the bathroom, I want you to wipe from front to back, never from back to front. So part of it is having that discussion. And I have the same discussion with my male patients. And just recently I had one, and the wife was in the room, and her eyes got really big when I started talking about this topic. And I said, am I embarrassing you? But I have to have the conversation because I don't want him to have a perineal infection. And he said it was okay. He was fine with it. But I do have that discussion with everybody. The other big discussion I have with everybody, just because I've seen this effect, especially this summer, we've had a really hot summer in Cleveland. And I've had at least 4 different patients who've called me up with dizziness, lightheadedness, drop in blood pressure. And in every one, I had them go get a BMP, and it was very obvious they were dehydrated. And so I'm very careful when I start this drug now, unless my person is still hypervolemic when I'm ordering it. I'm very careful to tell them to not be so picky about stopping, fluids. Some of my patients who were starting these drugs on are patients we've been seeing for years, and they were in the era of keep your sodium less than 2 grams and fluid restriction less than 6 cups or 8 cups a day. And now I'm backing off on that and telling patients, if you feel thirsty, I want you to drink, because this drug may make you lose a little bit of extra urine, especially during the first month when we start it. And I don't want you to get dizzy, because you're going to call me up or you're going to call somebody else up. They're going to hear your blood pressure's low and they're going to tell you to stop it. And it's such an important drug. I don't want you to stop it.
Well, such great clinical tips. And kudos to you for having these difficult conversations, because often our patients won't ask us because they'll be embarrassed. So it behooves us to bring it up proactively. And I had a similar experience when we talked about whether the gentleman was circumcised and whether or not that increases his risk of having perineal infections and such. So really, really good advice there. And same with the staying hydrated. I live in Denver, Colorado, where we run dry as well. Yes. And so a lot of my elderly patients, especially at higher risk for getting prerenal and having issues. So, Dr. Albert, this has been a fascinating discussion. And I know that the SGLT2s have really changed the landscape of how we think about treating heart failure patients. In fact, the American Heart Association proclaiming the CKM syndrome, cardiovascular kidney metabolic syndrome, I think has proven to us just what a CKM drug this class of drugs is, because we're seeing benefits with the heart, with the kidneys, with obviously a metabolic system as well. So any last thoughts before I let you go? You have a busy day ahead.
No, I think I would just like to say it's exciting to see that there's new literature out in the HFpEF and looking at different factors that could make it more important to use the drug. I think the more literature we get out there, the better, so that people will have a heightened awareness of the class of drugs as a whole and the different drugs within the class. So I think it's all great.
Me too. And I was aghast to actually see the data that less than 20% of patients who qualify for SGLT inhibitors are actually on them. So it's not because we're bad clinicians, it's just because the system, the more we look, the more we find. Yeah. And thank you again for this discussion. And to our audience, thank you for joining us. Until next time.